I'm currently using other device to use this.
Okay, the device that you are using is not capable to show anything, but we had a guy who could present on the iPhone terrifically. Okay, now let's see. I'm going to share this ECG. Okay, can you see it?
Yep.
All right, it's only one problem that you cannot control. So, but if I give you the mouse, you cannot control, yes?
Yes.
Okay, so, all right, so it's up to you. We are listening.
So as we can see, the heart rate is rhythmic.
Mm-hmm.
Uh, the rate is slow, but it's still normal. So we
Uh,
can see
is,
about,
okay, so is this rhythmic?
yes.
You have to look at, let's see, this long strip in a button, the V1.
Yeah, it's rhythmic except here, but it's in the sense it's rhythmic.
I don't think it is rhythmic.
But I'm gonna can I go there after? Well, I just want to go and talk about because
No,
I'll talk about PR interval and then R interval.
step by step. First, you have to look at the written strip. And you can see whether you do have a regularly RR interval or not. And you can see immediately that is not rhythmic at all, okay?
Oh, okay.
This is what it means, it's not rhythmic. Okay, the next one, you have to calculate the heart rate. It's not an easy to calculate the heart rate, but you had it at home, so you could do it. What was the heart rate?
Um, since you say it's not rhythmic, that's why I have to calculate. Okay. So can't really tell whether the box is this that indicates second. Is this? Um,
Okay, if you do not have rhythmicity, you have to count a longer interval, okay? Now, the best one, if you choose, let's see, for example, this is how many squares we have to have? We have to have at least 5 squares. 2, 3, 4. I think that's about the 5. I have to check it. Okay, I have to check it whether we do have 5 or not. Okay, 1, 2, 3, 4, barely 5. Wait a minute, I'm going. Okay, here, because here I can see much better the. Okay, all right. Okay. So 1, 2, 3, 4, 5. That's correct. Okay. So now I have 5. Okay. So let's see how many times I can have this 5. Okay. 1, 2, 3, 4, 5. I would say 6. Up to this point, 6. So from the beginning till this point, we have 6. 1,
there's
2,
4,
3, 4, 5, 6. So what is the heart rate?
50.
What? How much?
50
Why?
because 6.
If you do have 6 beats in 60, I mean that's 6 seconds. In 60 seconds, you have 10 times 6, so it's 60. 6, 0.
But is there 5? Oh, okay.
From here to this point, but you can measure the longer interval, so the rate is around 60. Okay, fine. Next one, do we have P waves?
Yes.
Okay, and are these P wave comes regularly?
I think so.
Hmm?
Yeah.
Yes, so we do have regularly coming P waves. Okay, however, not every P conducted, yes?
No.
So,
So I think it's a second degree AV block.
okay, so we do have a second degree AV block, okay? Because here we do not have any conduction. Okay, go on.
Wait, but since you said it's arrhythmic, I initially thought it was Mobius type 2.
Why?
because I initially thought because the RR interval was normal, like was sane, which is not true. So
I don't think that the RR intervals are normal or equal. But this is not the way how we do it. What we have to do, first of all, you have to compare the last conducted, okay, the last conducted PR, which is this one, okay. This is the last conducted PR, okay. And you should compare to the first conducted PR, okay. And this is the first conducted PR. What do you think? They are equal?
no, they're not.
They are not equal. Okay, so what does it mean?
It's a multi-step one.
That's a second degree AV block, Mobius type 1. Okay, now another thing, you should concentrate on the shape of the P wave. All right, so as you learn that the base of the P, so the length of the P should be around 0.1 second, so half square, and the magnitude should be about 2.5, maximum 2.5. But this is normal, okay? Great. Next one, the QRS complex. Is it wide?
No, it's normal.
It's normal. Axis?
Normal.
Okay, the axis is normal. Can you tell me the axis?
Well, based on the lead one is positive and AVF is positive.
So this is why you said normal. Okay, go on.
And then lead one is almost equiphasic, but not really. But
no, it's positive.
It's positive, slightly positive. So it's slightly pointing between 0 degrees to positive 30.
No. If its lead number 1 is the smallest one, it means that the axis should be close to 90, yes? So this has to be between 2 and the 3, but it's not 90 because positive, so you can say it's about 80. Okay? This should be about 80. Okay, next one. Do we have any pathological Q waves?
No.
No, we do not have it. Okay. Next one, ST segment.
Is isoelectric.
Yeah, it's mostly isoelectric, but here we do have a little ST depression, as you see here in 2 and 3, a descending ST depression. So that can indicate an AFF as well, all right? Can you see it? And we said that about 0.5 millimeter is enough to diagnose. So that can be an inferior subendocardial ischemia, okay? Now, next one, the size of the R wave. For left ventricle hypertrophy, we should summarize the V1, the S wave in V1, and the R wave in V5 or V6, whichever is greater. If it's bigger than 35, yes, we do have. Or alone in V5 should be bigger than 25 millimeters, but is not. So this case, we do not have any hypertrophy. Okay, so this is the diagnosis. So we do have a second degree AV block Mobitz type 1 sinus written, and possibly we do have an inferior subendocardial ischemia. Okay. All right. Now, the next one, is Ishtvan.
Yes, hello.
Can you share your screen?
Sure.
Share it, please, because now you can demonstrate much easier if you use that one.
All right, can everybody see?
Yes, terrifically.
Okay, lovely. So I'll start from the beginning.
Mhm.
Here you can, or can you see my cursor?
Yes.
Perfect. So you can see P wave, regular P wave. So it's a sinus rhythm. The
Mhm.
rhythm is approximately 75 beats per minute.
Mhm.
The axis of the heart, I saw that 1 is about equiphasic, AVF is positive. Um, 2 is a little more positive, so it's closer to 90 degrees, maybe 80 degrees.
Mhm.
Um, Now, PR or PR interval is fine. QRS complex is narrow. The obvious sign, which is also circled here, is there seems to be a T inversion in lead 1, as well as
I haven't heard anything about the pathological Q wave.
no.
We don't have.
Well, in 1, it appears to be a pathological Q wave. Actually,
And
I didn't pick that up because I didn't see a pathological Q wave in any of the other
yes.
leads.
And if you do see in lead number 1, which other lead that you have to look at immediately? Which are the surrounding leads?
Lead number 3.
Nope.
Nope. Okay, then no, I'm not sure.
High lateral.
Bilateral.
Which are the high lateral? Yes, somebody says
AVL.
something?
Yep.
Who said it?
Boyoung said AVL.
Boy, exactly, AVL or
or V6.
exactly V6. Exactly. So these are lateral V5, V6, and high lateral 1 and AVL. So this is a continuation of V6, V5, V6, 1, and AVL. So this is how they are ordered. So, but you don't see anything in V6, but you do see in AVL.
AVL. Yes, right
Okay,
here.
good.
So since I missed the pathological Q wave, the only thing I was thinking was some sort of lesion resulting in the inverse T wave.
No, the inverse T wave is ischemia, is not lesion.
Okay.
ST
So
segment is the lesion, okay?
all right.
But now you do have the pathological Q wave together with the T inversion. So that represents?
A pathological Q wave with a T inversion is acute MI.
Nope.
T inversion?
A Q wave and T inversion.
Oh, it's old infarct.
Well, subacute. Let's say
Subacute,
that's a
subacute. Okay.
subacute. Okay, subacute. Of course, in an old case, you can see any kind of T wave, but let's remember that, okay, if it's a subacute Q and T inversion, old one, only the Q wave that's represented. Okay.
Okay.
All right, that's fine. Any question to Istvan? No. So the next one,
Right, thank you.
next one, thank you. Wasan.
Hello.
Hi.
Hello. Can you hear me?
Now I can hear you. That's what. Hello.
I'm sorry because I had an appointment at the hospital and it took long, so I'm attending from the
Oh,
hospital.
okay. Can you share the screen?
No, I'm sorry.
No, but I can do it, and you have 118. Okay, I'm going to share it, and you are going to present it. Okay, and I'm entertaining than others. Okay, let's see. Now, tell me your story.
Okay, so what I'm seeing is that it's a rhythmic. It's rhythmic, and the heart rate was 50 beats per minute because I counted it at home. It was 6 squares, and I
Okay.
did 300 divided by 6,
Okay.
which
All
was
right.
50.
Super.
And I think it's bradycardia because it's 50.
Mm-hmm.
And the axis is extreme right deviance because
Okay, because you do see,
lead 1 is negative and then AVR is positive.
okay,
So
exactly.
it's extreme right deviance.
Okay,
And,
so it's more than 120. Okay, more than 120. Okay, go
yes.
on.
And I also do see pathological Q waves in lead 2.
Is the PR interval or the P wave is okay?
I see that it was okay.
Okay,
Because
good.
I counted in lead 2, the PR interval was about 0.12 seconds.
Terrific, terrific,
Yes.
terrific.
I
Okay.
see pathological Q waves though in lead 2 and maybe 3, and then in the chest leads V2.
Why don't you start with lead number
Yes,
1?
V2, V3, V4, V5 has also
What?
pathological Q waves, and there are
Slow
also T
down, slow
inversion
down, slow down, slow
in
down.
V4, V5.
Jesus Christ. Okay, slow down a little bit. Okay, so you do
Sorry.
see Q wave. Okay, you do see Q wave. Lead
Sorry.
number 1, lead number 2, lead
Yes.
number 3, AVF. There is no Q in AVL. Okay, however, V2, V3, V4, V5, V6. Correct.
Yes.
Okay, good.
Also in V4, V5, and V6, I see an RSR, the M shape.
No, this is not.
No?
That's a Q, muscle is QR, or maybe the J
Okay.
point, but this is nothing. That's a Q and R. This is not an RSR pattern. It's not. And you should see the RSR pattern in V1, V2, and not in V4, V3. Okay.
Okay,
So
because I thought
that's
that was left, but it's
no,
not left BBB.
no. It's a right should be, but this is not. Okay, so there is
Okay.
no bundle bench block because the width of the QRS is okay, and it's neither incomplete because there is no way that you do have any RSR pattern in V1 or in V2. Okay, but what else you can
Okay.
see?
The ST segments seem
Mhm.
normal. They're not elevated.
Very good.
So if we have the pathological Q, then it might be an old myocardial infarction or subacute.
Let's go step by step. Okay, let's go step by step. Now,
Okay.
you focused on the chest leads. V2, V3, V4, V5, V6, and lead number 1, because these are the anterolateral leads. We do have Q wave
Yes.
and negative T wave. So these are
Yes.
represent subacute MI in the anterolateral or extensive anterior. Okay?
Okay.
But what about 2, 3, and AVF? Can you see any kind of T inversion?
No.
So what does it mean?
It means it's not anterolateral. I'm not
That's
sure.
an anterolateral, that's a subacute. Okay, that's fine. But in the 2, 3 AVF, we do have Q wave. So that meaning that's an inferior part, okay? And
Okay.
so we do have necrosis sign, but there is no ST or T changes. So that means we do have an inferior definitive or old inferior MI.
Okay.
Okay,
Okay.
good. Everybody understood?
Thank you.
Yes, sir.
Okay, let's see the next one. Okay, let's see next one. Okay, so far the first 3 was good. All right, I have to mark them. And George? George is not?
Yes.
Okay, can you share your
Yes, yes,
screen?
yes. Sorry, I'm here. It's just that my computer is a little old and slow, but I'm here.
Okay, but now your computer is getting faster than you. So can you share?
Yeah, I can.
Okay, do it.
Sure. Mm. I don't know if it's already visible.
Almost. We can see your name And now I can see your, let's see, tracing as well. Okay.
Perfect. Shows that. All right.
But
It's
that was a
saying
previous one.
yes, exactly. I'm sorry, it's just taking a little while. Um,
Relax. Be
sorry about that.
patient. Be patient.
Yes.
Okay.
All right, perfect.
Mhm.
Well, to start off with, we can see that this ECG is rhythmic.
Mhm.
I counted around 3.5 boxes
Mhm.
between our waves, which gives us 85 bits per minute.
Mhm.
We can also see visible P waves, which indicates sinus rhythm.
Mhm.
For the electrical axis, we can see that lead 1 is positive, AVF is negative mostly,
Mhm.
indicating left axis deviation, and in case of lead 2
Mhm.
being slightly more positive and the
Mhm.
closest to equiphasic,
Mhm.
we can see that I would say that the electrical axis is between -20 and -15 degrees.
Mhm.
Um, then from there, I was able to observe to start off that the QRS complex in case of lead 1, for example, in AVL, is a little longer than 0.12. It can be 0.12 or 0.16 even here, which indicates, well, we have a wide QRS. We can also see, let me see if I can zoom a little bit. All right. In case of lead 1, AVL, V5, and well, not very observable in V6, but right here we have a notched R.
Mhm.
And I believe, I'm not quite sure, but I
I
believe
believe. I'm a believer. Yes.
that in case of V5 and V6, I don't see a proper Q wave, which would give us elements of a left bundle branch block.
Yes, left bundle branch block. It's if the QRS is wide and you do see in the left side nudged or wide R wave, you can see that's a left bundle branch block. Now, pathological Q wave, let's see.
All right. In case of a pathological Q wave, I was not sure if it's a pathological Q wave or if it's a QS complex. Because for example,
Go, let's see in order. 1, no. 2, no.
yeah,
3, no.
exactly.
AVR, yes, but it doesn't count. AVL,
Exactly.
no. AVF, no. V1, V2, V3, yes. So we do see in the anteroseptal leads, we do see pathological Q wave. However, due to the left bundle branch block, we should see QS complex on the right side. This is why you said it in V5, V6, you do not see any Q wave, proper Q wave, and this is how you summarize your diagnosis. So the septal activation is abnormal. This is why you don't see an initial R in V1, V2, V3.
Okay.
Okay, so this, what you do see here is a pathological Q wave, but this pathological Q wave does not represent MI. It represents a left bundle branch block.
That would that be like a secondary polarization abnormality?
And you do see a secondary abnormality, a reposition abnormality in V5, V6, and V2, V3. Yeah, exactly.
Okay. Okay, perfect.
All right. Is it clear for everybody? Good.
Yes.
All
Yes.
right. Yes, yes, yes. Lydia, Lydia.
Hello.
Hi, Lydia.
Hi.
Can you share your screen?
I will try.
Okay, let's try. That should be 163. Oh, wow, that's a nice one.
Okay.
So far, so good.
It's about to be happening.
Okay.
Yeah. I think I did it.
Yes, you did it.
Okay. So we have a normal axis because of B, and then we have a, I would say, irregular, like
Cool.
it's non-rhythmic, I would say.
Yes,
Because
you can say it.
we can see the difference between the RRs are like not this one, sorry, like getting longer, so it's irregular.
Are you here? Lydia. Well, looks like she disappeared. Come on. Yeah, Lydia disappeared.
Hello?
Yeah, you are back. Okay, something happened.
It disconnected, but how much did you?
Well, not too much, not too much. Okay, now I can see you again.
What did I say last?
The last that is arrhythmic because the RR intervals are not equal. Okay, that was the last one.
Okay, thank you. So yeah, it's non-rhythmic because the RR intervals are not equal. I said normal axis. The PP intervals are like relatively more similar.
Okay, except look at in V1.
Except yeah, in V1.
Look at in V1, not in all the way down at the bottom when you do have the rhythm strip. Okay, now the first two is okay. Yeah. After this is not, but the other ones are okay as well.
Yeah, that's why it's Mobitz type 1 AV block.
It's true. That's a Mobitz type 1 AV block.
Mobitz type 2 and
No. Mobitz type 1. That you said correctly. Because if you look at the PR interval, okay. Can I have your cursor? Can you share your cursor with me? If you go up. Okay. You are controlling. Now you can see it. Okay. Now I'm controlling your mouse. Okay. So these P are regular. And this P is not followed by QRS. That's correct. And if you look at the last conducted PR compared to the first one, fine. This is Mobitz type 1. Now, I'm curious about this. Oops, come on. Okay. Wait a minute. Yes. Okay, maybe this. No, it doesn't work. Okay. So, what did I do? I did something. Oh boy. Oh, that's. Yeah, because you are sharing from the nettar. Yes. Okay, and this was that one. And I cannot magnify, that's the problem. Okay, wait a minute. Okay, good. Now you can magnify and go down. So look at the PP interval. P, oops, oh, that's okay. P, 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 P. See, something happened here because these are the PPs are not equal. This bit is not a conducted bit.
Yeah. It's not, so that's why it's a second degree Mobitz type 1.
No. This is not conducted. Okay, this is not conducted.
Yes.
But this is the QRS complex. Here you have a P and no QRS complex. Here I said P is inside the QRS complex. And this is why I said this is another bit. So that bit is a possible an escape bit.
Escape bit, okay.
Because if you look at, let's see, the last conducted PR, this is the conducted, but the last one, the longest one. And here it's very, very long. So somehow here you had another block. And before another P could, let's see, come, we had a ectopic bit originated from the AV. So this is why this bit is a junctional escape bit. And after everything comes back to the normal. Okay.
Okay.
Everybody could see it.
Yes.
Yes.
I think so.
I think so. So the problem is if you are comparing, that's the normal regularity when we do have a second degree AV block Mobitz type 1. This part, the last part, that's okay. However, this is different because here, if we, let's see, if we had this gap, okay, we should have a gap with a normal PP interval. However, because we do have this QRS complex right here, meaning that the PP, because it should come regularly, the PP. And this is not exactly twice as much as the PP is longer than twice as much. So this is why we do have an extra bit that came here. And because the PP is inside the QRS complex, so, and this is K in the area when we had no conduction. So this is why is a junctional escape bit. So the junction is firing earlier. Okay? No. Go on and let's see the P wave and another P, the QRS complex, the read, the axis. Now you can go and do it. And pathological Q wave, if you do have.
Oh, well, we don't have one here. And I think the yeah, like I already said, like the axis is normal because this lead 1 is positive.
Okay, yes, it's very good.
AVF is a bit positive and then lead 2
Okay.
is positive. So the degree is like about 90, I think I would say.
So the QRS is not wide. There is no pathological Q wave.
No. Yeah.
That's it. Only what we have. Yes, correct. Yeah. Very good. Very, very good. Any question about this ECG? Okay. Odysseia.
Yes, I'm here.
Okay. All right. I could see that Yuli from, let's see, the Thursday group is here as well.
Yes, I'm here too.
Okay, don't worry. You will get another ECG. I'm giving you another ECG and you can do it. Don't worry. So now we concentrate on Odysseia.
Okay.
All right. Let's share your screen.
Yep. So can you see my screen?
Yeah, terrific.
Okay, so firstly, I can see that the rhythm is rhythmic. Also, we can see the P waves, so it's a sinus rhythmic. It's sinus rhythmic. Approximately the heart rate, I said it's about 85 beats per minute because we have like 4 small squares between the waves.
All right.
Then I move to here V2, which we can in V1 and V2.
Don't jump, don't jump.
No.
Okay, first of all, you have to look at the P wave. Is it normal?
I would say yes.
Good. PR interval.
Normal
good
distance, 0.12 seconds.
Very good. What? Okay, that's a little bit wider than 0.12
Okay.
because from the beginning of the P till the beginning of the QRS. Okay.
Yes. Okay.
Now, next one, the width of the QRS.
Narrow.
This is narrow. Count it.
No,
But
it's
you can count it in V1 as well.
it's wide QRS.
You do have a wide QRS. Okay, go on.
About the axis, I forgot to say. It's left axis deviation because we have positive lead 1, negative AVF. So it's left axis deviation.
This is the pathological left axis deviation.
Yes.
Okay, because lead number 2 is negative.
Lead number 2 is negative.
Okay,
yes.
go on.
And because of the wide QRS, I think we're going to have a left anterior hemiblock.
No.
No.
Hemiblock is not going to elongate the QRS complex. Okay? It's only causing not only causing a deviation, axis deviation. So
because of the axis deviation, we have a left anterior hemiblock.
Yes, that's correct in this case.
Yes.
And why the QRS is wide?
I'm not sure about that.
Yeah, you know it because you jumped immediately to V2.
Yeah. Because of the right bundle branch block?
Yes, that's it, because we do have an intraventricular conduction abnormality. And you do see this RSR pattern in
Here
V1 and V2.
Yeah.
This is why you diagnose that's a right bundle branch block. And together with the anterior hemiblock.
A fascicular block.
Yes, okay. Okie dokie. That's it.
Yep.
All right, good. Now let's see the next one. Sound.
Here.
Okay, good.
Okay.
Here. Okay, here. Okay, let's share your screen.
Can I actually do it on your screen if it's possible?
Yes, you can use my screen. You can abuse my screen. No problem about it. Okay. And how much was your number? 169, yes?
I'm sorry, I thought it was 214. Is the name someone?
Wait a minute.
That's what I heard.
I check it. Okay, 169 is yours.
Oh, I don't think it's me then.
I think it's mine.
Yes, Sangwon. That's it.
Yeah, Sangwon. Yeah.
Yeah, Sangwon. Okay, so do you want to use my computer screen or you can share yours?
Yes, sir. I can't share right now.
Okay, share it.
Okay. Oh, I can't share it, sir. You have to show it up on your screen.
Okay, I do it for you. Just for you and just today.
Thank you.
All right, and I give you the mouse. Hopefully you can use the mouse, yes? No, you cannot use the mouse either.
I don't think so.
You are on phone or what?
Yeah.
Okay, but somebody did it on a phone and an iPhone, and he was a wizard at that time. I don't know who was that one, but he presented very nicely everything by using a phone. Okay, now, all right, I do it for you. Now tell me your story.
So I just had a overall look, and you can see it's non-rhythmic. And if you look at V1, you see that abnormal QRS complex, and before that, I want to talk about the heart rate, which is around 65 beats per minute. And I looked at the RR intervals and decided that it's fully compensated, and you could see that this is actually a ventricular premature complex.
Very good, very good. Okay.
You don't see, the wave is missing, the P wave is missing.
Okay, that's a ventricular premature beat. That's period. Okay, that's great. Okay, go on.
And then I got the axis.
Okay.
And decided that, wait a sec. Where did it go? Looking at looking at lead 1, it was positive. And then I went over to the AVF, and the AVF was actually negative.
Okay.
And then the one I moved over to lead 2, and lead 2 is, as you can see, positive, and that's how I decided it's left deviation.
Okay, very good.
And after that, I was looking at the where is it?
The P morphology of the P wave, the PR interval.
Yes, the PR interval seems to be normal.
Well,
Or
you have 12 leads. You should look at the all
yeah.
12 leads, okay?
Okay.
Because that in lead number 1 is a very slightly started to increase. Let's see the baseline. In lead number 2, you do see nothing. However, in V1, you do see something, okay? And in V2 as well, in V4, and in V3, okay? What can you see? That's a PR is short.
Mm-hmm.
And?
Okay, and where is it?
PR is short, and you can see something at the beginning of this QRS complex. See?
Mm-hmm.
A little delta wave.
Oh, I can see. Yeah.
Well,
well,
teeny tiny, but is there, yes.
Mm-hmm.
This is why you have 12 leads. And if any of the lead, you do see the PR is shortening and you do see the widening, the first part of the QRS that's possible is due to WPW syndrome.
WPW, yeah.
And which type? V1 is positive, so that possible is a type.
A type, okay.
Mm-hmm. Is it clear for everybody?
Sorry, why is it left deviation when AVF is?
Because lead number 1 was positive. You are on the left side. AVF, only one bit that we do have a normal QRS complex, is mostly negative or equiphasic. Or you can say that's a 0, or you can say it's a little bit less than 0, maybe minus 10. And this is why he said that's a left deviation. But not extreme left deviation because lead number 2 is positive. Okay. All right.
In lead 2, oh, it just.
It's okay. I can share it again. Yes, in lead 2.
In lead 2, does this count as P pulmonale?
Well, let's look at it. If it's bigger than 2.5, yes, but this is not. This is about 2.5. Maximum is 2.5 or 2. This is not P pulmonale. Believe me, you will see that tall P wave.
Can you explain what's a P pulmonale?
P pulmonale is a right atrial hypertrophy. That was your homework, that you should watch the video.
Oops.
Oops. Yes. Oops. 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 Oops.
Thank you very much.
Odysseia, you heard that one? Huh?
Yep.
Yep. Okay. And especially if you do have P pulmonale, the initial phase of the P wave in V1 should be bigger than a terminal one, and it is not. Oops. Okay. Now let's see the next one. The next one is Binium. Binium? Not here. Okay. Okay. Yaunki?
Yeah, I'm here. Can you hear me?
Yes, very
Okay.
nicely.
I'm going to share my screen then. Okay.
Now let's share your screen. What can you do? Wow, I can see your
Can
screen.
you see my screen?
Wow, terrific.
Okay.
The best screen, whatever I see.
Okay, I will start from the rhythmicity of this ECG and look at these P waves and V1s here. They look quite rhythmic, and they are about like 5 large squares. So I believe this is the 600 bit per minute. 60, I'm 60, yeah. And if I look at the lead number 1 is positive, and lead number 2 is they're negative. So it means the extreme left deviation.
Correct.
And since AVR is also negative, so the range is between negative 30 to negative 60 degree, I guess.
Correct.
And then.
Are you using OneNote?
No, I'm using I forgot the name of it, but some PDF annotation application.
Okay.
And then if you look at the V6, we can find this premature ventricular bit, I think.
Where? No,
And
it is not premature. It cannot be premature. Premature meaning that it coming earlier, but it's not coming earlier. Okay, don't jump to the T wave. T doesn't say anything. Okay, not yet. So let's erase the last two, whatever yellow one and whatever written on that one premature. Delete it. Delete it. All of them.
Yeah.
Yes, correct. Now, so far you said rhythmicity. So far you said that we do have an extreme left deviation. Correct. Now the next one, look at the morphology of the P wave. Okay. Whether this is wider or taller or whatever, you can look at in lead number 1, for example, the P wave. Okay. Let's enlarge your screen.
Oh, yeah.
Let's enlarge it.
I think, okay.
Okay. So
I think it's taller than normal.
What can you see? Let's see in lead number 1. If you are looking at, I cannot control your mouse, so can you share your mouse?
Yeah.
Okay. Please do it. Not that one. No.
How do I share it?
No, you have to go all the way up. Push the cursor up. When you do see this green, whatever. Okay. And after you can see a mouse.
But I'm using it from the browser mode, so I don't think I can granting you the authorized to use my mouse. I never used.
Okay, that's fine. Okay. So that case, forget about it. Okay. Okay, let's go back to there. Okay, now, so if you look at, let's see, leave the screen here. In lead number 1, let's see the P wave, the first P that you can see here, that's notched. Can you see this notching in the P wave?
Is it notched?
Yes, a little bit notched, okay? So a notching P could indicate a P mitrale or left atrial hypertrophy. It's not for sure because it's not so wide, but you can mention that because the P is notched, it's possible this patient has a left atrial hypertrophy. Not the R wave, the P wave is notched. Okay, left atrial hypertrophy. Okay, everybody can see it.
Okay.
Okay. All right. Now, the PR interval is okay. That's fine. Now, the next one, the width of the QRS. Is it wide? It's your turn now.
QRS.
Is it wide?
No, I don't think so.
No. Okay, that's normal. Very good. Okay. The next one, pathological Q wave.
Okay, so I thought there are several pathological Q waves around here. I'm not sure about it, but this one.
That's a T wave that you marked it in green.
Okay. Yeah.
The QRS complex should be looked at. Okay. Lead number 2, you do have pathological Q wave. Lead number 3, you do have pathological Q wave. Yes? Lead number 3. Not that one, that's a T wave. Yeah. AVF. AVF. You do have pathological Q wave. AVF. Yes. In V2, V1, V2, V3, also we do have pathological Q wave. And in V4 as well. And in V5 as well.
Okay.
Okay. Not the T, not the T, not the T. Yes. Okay. Now, so we do have pathological Q wave in the inferior leads and in the anterolateral leads. Okay.
So actually, I assume that is the old inferior myocardial infarction.
Wait. Don't jump. Okay, let's see. Now, let's zoom into, let's see the 2-3 AVF. Because now we are interested in the ST elevation. Do we have ST elevation or not? How much should be the ST elevation in the limb leads? At least 1 millimeter. And here, if you look at lead number 3 or AVF, that's about 2 millimeters. Yes, we do have ST elevation. Meaning?
Myocardial infarction.
Which stage?
Elevation, acute.
Acute, exactly.
Hello.
Hi, I am here.
Oh yeah. I lost the connection for a while.
No, the connection is still here.
Okay, maybe I lost that.
Okay, so we do have ST elevation. Yes.
Acute MI.
Exactly. So we do have an acute inferior MI. But let's go to the anterolateral leads.
Anterolateral.
V1 to V5.
V1 to V5.
Do we have ST elevation? And how much should be the ST elevation in the chest leads?
About 1 millimeters.
2 millimeters. And this is not.
Not.
So we do have a, or you can say an old, or you can say subacute, because in V4, V5, you have a negative T wave, but in V2, V3, not. So both accepted, you can say that's an old one. So this patient had an old anterolateral, and now the patient has an inferior acute MI.
Okay.
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 Good. Is it clear? Any question?
In the 2, 3, and AVF, how can you know if it's a pathological Q and it's not the S?
Okay, so wait a minute, I'm sharing it. No, I'm going to share it.
Okay.
Okay, so lead number 2 and lead number 3. This is the first negative wave. There is no initial R wave. The S wave is behind of the first R wave. Because you don't have any R here, that should be as a Q wave. You can see very nicely in AVF because that's an R. So this is a Q, okay?
Okay.
Clear?
So there is no S, or the S is like
There is
where?
no S. There is no S.
And
You
is
can
it
say that's a
pathologic?
QS. Yeah, but here you can see a little R. Okay, so this is the first. QS is a pathological Q wave as well. But it's so deep that this is why we said in V2, that's a QS complex. That's a QS complex. QS is a pathological Q wave. Okay.
Yes, thank you.
All right.
Sorry, another question about this one. So you mentioned that the left atrium hypertrophy was told through the notched P wave.
Yes.
All right. So okay, thank
you. Okay. The next one.
I think it's me now.
Wait a minute. Subong?
Yes, someone.
What?
Someone. You can call me Peter.
Peter, Jesus Christ, much easier. Thank you. Thank you, Peter.
No problem.
Okay, can you share your screen?
Could we actually do it with your screen, please?
Oh, why not? It's a pleasure to me to share my screen.
Thank you.
Okay. Now, which one was this?
Yes.
Now, Peter, let's see.
Yes. So this is not rhythmic because of that part. And the heart rate, I think, is about 60 beats per minute.
That's terrific. Okay.
Axis is left deviant, lead number 1 positive, AVF bit negative, but lead 2 is almost equipotential, so I would say almost minus 30 degrees. The P wave is a bit problematic, especially in the lead 2.
How does it look like?
There's like two bumps, so
yeah. So notched.
Yeah, it's a notched P wave.
So.
Excuse me.
So.
Yeah, it's a notched P wave. So.
We already had one.
Yes, okay. It's a left atrial hypertrophy.
Or P mitral. Yes. Okay. Correct.
Also. Yeah. Okay. And there is ST elevation.
PR interval first.
Excuse me. The PR interval is normal.
Width of the QRS.
Width of the QRS is not normal, especially in the chest leads.
Where? Which lead is that?
So the 4, 5, 6, and 1.
Yeah, but this is only one bit.
Ah, okay.
What kind of bit is this? It's completely different from the others.
Is it ventricular? Derby?
Ventricular?
Ventricular escape?
No. It's coming earlier, not later. Premature beat. Premature beat.
Okay.
Okay. Now, but the width of the other QRS are fine. Okay. Next one.
Okay.
Pathological Q wave.
Pathological Q wave can be seen in lead number 1 and AVL.
Okay.
Yes.
But nothing else. Okay. And immediately you should look at the ST segment as well.
ST segment, yes. ST segment maybe in V2 and V3, but I don't think it's over 0.2 millimeters. So
Relax. Whenever you do see the pathological Q wave, you should look at the ST segment immediately. Okay, because this is
yes,
what
okay.
you would use to diagnose acute or subacute or definitive. Now we do have in one an AVL, the Q, and the ST segment is not changed.
Yes,
Only
it's not
what you do
changed.
see that T is inverted, okay?
Yes.
All right, now if you go to here in V2, V3, this is not ST elevation because the J point is not elevated. Okay, this is not elevated. This is ascending STT, so this is not, okay, it's not elevated. Only what you do have a high lateral subacute MI. So if you want to summarize, that's a sinus written with ventricular premature beat, P mitrale, and a high lateral subacute MI. That's it.
Okay.
Okay.
Thank you. Yes.
Any question?
Nope.
All right. Next is Fadl.
Yes, I'm here.
Okay. Can you share your screen?
Yes. Is it fine? I have annotations on my EKG.
Yeah, it's good. It's very good. That's the best one that you could have.
All right. Just a second. Okay, here we go.
Ooh.
All right. So, shall I start? So first, I just calculated the electrical axes. I found the heart rate. Shall I just jump to what was like my remarks?
Mm-hmm.
So my PR interval I calculated was 0.36. So it was too high. So I kind of thought of maybe a first degree heart block because it's over the normal range.
Yeah,
and
but this is not rhythmic, you said.
It is rhythmic.
Well, if you look at the V1, you always should look at, let's see, the long strip in V1.
Mm-hmm.
That is not rhythmic, not over there at the bottom. Where you do see this red mark with RR dropped equal with 2 times RR.
Oh, yeah. Oh, yeah. So, because I had like multiple, I'm not sure, like I have 3 different like diagnoses for this one because I also had an elevated ST. So,
yeah, but relax, step by step.
Sorry. Okay.
Step by step. Can you share your cursor?
Yes, I can. Just
Please give me your cursor. Okay.
All right. Okay.
Yes, okay. Now, first of all, this is arrhythmic, as you said. Okay.
Yeah.
You said the heart rate is around 83 beat per minute. That's good, very good. Now, we do have P waves, okay? So we can say that we do have a sinus rhythm. However, not every P is conducted, okay? This is why we do see that's a second degree AV block. Good,
yeah.
Very good. Now, don't use the RR interval. Only use when you do have a sinoatrial block, but we don't have sinoatrial block. Let's see the last conducted PR, such as this, and compare to this. You will see immediately they are not equal.
Yeah.
Okay, so this is why is Mobitz type 1.
Oh, okay.
Okay, Mobitz type 1. Next one. Looking at the P wave, okay, the shape of the P is okay, it's normal. PR interval, you don't need to look at the PR interval because you had a second degree Mobitz type 1, period. You don't need to look at whether this PR is longer than 0.2 or not. We don't need it.
Okay.
Next one. The morphology of the P was okay. QRS. QRS is narrow. The axis, as you said it, was, as you calculated, about 80 degrees. Okay, let's see. 80 because 1 positive, AVF positive is normal for sure.
It's
And
30.
Pardon me?
30 plus 30, the electrical axis.
I don't think so. Yeah, 30. Yes, it could be 30. Okay, yes, it's 30 because, yeah, that's a 3. And that's okay. That's a 3. Good. If you say so, that's fine. That's fine. Okay, so this looks like is normal. And 1, 2, 3. 3 is equiphasic, it looks like. And this is why it's around 30 or a little bit less than 30 because lead number 1 is bigger than lead number 2. It's fine. Okay, good.
Okay.
Next one. Do we have pathological Q wave? Well, No, no,
No.
yes.
Oh, okay.
Yes. So 3 and AVF, we do have pathological Q wave. And immediately, we already marked it, we do have ST elevation as well.
Yes.
Okay. By ST elevation, the biggest one in lead number 3, 2, and lead number, the AVF and 2.
Yeah.
So if you remember when we discussed the right ventricle MI, we said that the ST elevation is the highest one in 3 and after AVF and 2. So possible this guy could have a right ventricle MI as well. But we don't know because you don't have any kind of right ventricle lead. Okay, let's go on. So here it's indicating that we do have an inferior acute MI. Good. We know that inferior very frequently comes together with posterior, okay?
Yes.
What should be the mirror image? We should see a tall R and an ST depression. Well, this R wave is not too high and ST depression is not, well, if you can get closer, can you get a little bit closer? Maybe I can use this.
Yeah.
Okay. So in V2, I don't think that we do have any ST elevation or ST depression, maybe 1 millimeter. Yes, we do have 1 millimeter. So if you do see this, if you consider that is 1 millimeter, you can say that, yes, possible we do have a posterior MI as well. Okay.
But from V4 to V6, aren't the R waves exaggerated?
Okay, that's another story. That's another story. We are getting to that other story. Don't worry.
All right, sorry. Okay.
Okay, so we do have an infero-posterior acute myocardial MI. Plus, if you look at the V5, look at the V5, how big the V5 is. Okay, up, up, up. Okay, look at how many millimeters. If I calculate, it's 10, 20, 30, almost 30 millimeters. So that meaning, we do have a left ventricular hypertrophy as well.
Yes.
Okay. No, that's it. Period.
Okay, so all right. So like I would just write down left ventricular hypertrophy. Like, because I thought there was also like a 1st-degree heart block because of the long PR, but you said I shouldn't look at the PR.
No. That's a 2nd-degree AV block, Mobis type 1, plus an acute infero-posterior myocardial MI with left ventricular hypertrophy.
And just one more thing, like what I marked in purple, like those just random gaps, is that because of the same thing as well?
No, it's not a junctional because that's due to the 2nd-degree AV block.
Oh yeah, sorry. Okay, all right.
So that's a P wave. And if you had, let's say, a junctional escape bit, possible the P would not be positive on the left side. It has to be negative on the left side.
That's right. Okay. All right.
Is it clear, everybody?
Yeah, it's clear. Thank you.
Yes.
Okay, Nicolette.
Hello.
Hi. Can you share your screen?
Yes.
Oh, wow. Okay. Listening.
Okay, so this one is rhythmic. I said that the heart rate is around 150 beats per minute. So
okay. Tachycardic. Okay.
And the axis is normal. There is a wave. So
Wait a little bit. I am back. I'm sorry. Okay, I'm here.
I said that there is a P wave.
Okay, yes.
So for them.
So that's a sinus tachycardia, you can say it, okay? Go on.
And then the PR interval is also normal.
Okay.
The QRS complex is narrow.
Okay.
And there is ST elevation.
Okay. First of all, before you jump to the ST elevation, there are two things. Is the QRS wide? No. Next one, pathological Q wave.
So we have the pathological Q wave here.
2, V2, V3, V4, V5, and possibly in V6, we do have a 1/4 of the R. Okay. Okay.
So,
and possibly in lead number 1 and, well, it's not too much. Okay. And now you can jump on the ST elevation.
So we have a ST elevation in lead 1.
Mm-hmm.
And then also in AVL.
Mm-hmm.
And also here in V2.
2, V3, V4, V5, V6, lead number 1, and AVL. Yes.
There's
so,
also ST depression
okay.
in AVF.
Yes. So,
I said that it's acute extensive anterior MI.
very good. And in 3 and AVF, the ST depression is due to
Is it ischemia? I'm not
mirror image.
Okay.
Because AVL exactly the opposite of lead number 3, almost opposite of lead number 3. Yes?
Yeah.
Okay. Terrific. Very good. Everybody satisfied with her?
Yes.
Okay, good. 7. Are you here? No. 7 is not here. Okay, don't worry. 219 goes to Yuli Glassman. Okay.
But I think she wrote now in the chat that she is here.
Hi, can you hear? Now I can hear you. Wow. See, he doesn't want to give you this nice ECG. Okay, yeah. It's his ECG, not yours. Okay. Now let's see. That means 219. Can you share your screen, 7?
We cannot hear you.
Me or 7?
Oh, Sevin, she is asking in the chat.
Yeah, but hi, can you hear me? Hello. Can you hear anything? No. The iPad should work. Yes, I can. It's fine. Okay. Now somebody can hear? No. We cannot hear you. That's the problem. You can try to log out and log back. But iPad, okay, sorry, let me leave. Okay, bye-bye. No. Okay.
Hello?
Yes, you are here. See, I think your iPad slept a little bit. Okay, now yours is the 219. Can you share or no?
No, sorry, I'm on my iPad.
And what does it mean?
I can't, sorry.
Okay, iPad is a very good, let's see, pad. Okay, now I have to share my screen. Okay, yes, it's right here. Okay, good. Wow, that's a nice ECG. I like this ECG. Okay, can you use your cursor?
1 second.
If you do have a pencil, you can use it. If I give
you hand it
you
over
the,
to me?
okay, I'm going to hand it over to you. Okay, 7777. I have to find you. That's okay. Lily. Yes, I got you. Now, see? Wow, it's moving terrifically.
So I think the axis first is normal. Because the lead one and AVL are both positive.
Rhythmicity.
Is it arrhythmic?
Yes, it's arrhythmic. Okay, go on.
There's the long TP interval.
Can you see P wave? The
No.
next question. Okay, there is no P wave, so arrhythmia, no P wave. Arrhythmia, no P wave.
Is it atrial fibrillation?
Don't ask, say it loudly.
Atrial fibrillation?
Yeah, that's it, immediately. Okay, go on. No, we don't need to talk about the P wave. We don't need to talk about the PR interval. We have to jump on the QRS complex. Okay, is it wide or not?
I think it's normal.
Normal, it's not wide. Very good. Okay. However, if you look at in V1, okay, R, S, R.
Yeah.
So, and on the left side, you do see a wide, that's a walking stick, S wave. So,
is it right?
Yes.
Incomplete right bundle branch block?
Yes. Great.
Um,
Okay. Pathological Q waves.
V3.
V3. No. RS. No. Nope. Here, yeah, it's RS here. Oh, look at that one. Lead number 3. Only in lead number 3. We don't have any other leads. And especially together with the negative T wave.
Yeah.
So we do see a deep S in 1 and Q and T in 3. S1, Q3, T. Oh, if you watch the movie about the ST segment changes and other.
Is it the heart strain?
Nope. S1Q33. This is how they call it.
Pulmonary.
No, that's called pulmonary embolization, pulmonary embolism. About 20% of the cases, we do have this S1Q33. Now, what does it mean? We do have an acute right heart side failure, meaning that we do have a very strong stretching of the right atrium. This is why it can be atrial fibrillation. And the right side, we do have an abnormality conduction, so the right bundle branch block. And if you do see this right bundle branch block, not every QRS complex follows the pattern of the right bundle branch. So it's meaning this is not a third degree, that should be a high degree right bundle branch block, okay? So it's not completely blocked, okay? And in only 3, you can see this Q wave, nothing else. And this is why you don't have any MI. Because if you talk about MI, you have to have the pathological Q wave in 2 consecutive lead, or in AVF and lead number 3, or lead number 3 and lead number 2, but only in lead number 3 and a negative one. So this is very similar to the atrial fibrillation. If you do see S1Q3T, immediately you can say that's a pulmonary embolism. Okay, or acute right heart failure. Is it clear?
Yeah.
I like this ECG. Okay. The next one goes to Boyung.
Hi.
Finally, who drew this picture? Is it self-made?
Oh, it's no. It's a girl that I used to. It's a little baby girl. Like I used to babysit. Like yeah.
Okay, and
Yeah, a long time ago.
she was drawing from you this picture.
Yeah, she drew me.
Okay,
Yeah.
please turn your video, and I want to compare this picture to you.
Oh my God.
Yeah. Okay.
Oh my God. Hi.
Yeah, almost. The glass is terrific. Yeah.
Sorry, I didn't close my closet, so yeah.
No, it's okay. You can turn your
Yeah,
video
okay.
off, no problem, because the internet
Okay,
connection is
sorry.
not
Yeah.
good. Okay,
Yeah.
can you share your screen?
Okay. Let's go. Sure. Thanks. There you go.
That's great.
Okay.
Mhm.
First of all, we calculating the heart rate is about 4 big squares, meaning it's about 75 beats per minute. And then we can see rather positive, maybe equiphasic, but I would say positive. Positive lead 1, positive lead 2, and positive AVF.
What is positive in lead number 1?
It's not really positive, it's equiphasic actually.
Well, I would say negative. I'm
Negative?
sorry, but I
Really?
have to inform you that if you
Is
summarize the
it
positivity,
strongly? Okay.
okay, not strongly, but
Okay.
at least it's close to the 0 or a little bit
Right,
negative.
right,
AVR is negative, so this is
right.
why we do not know whether it's an extreme right deviation or not, but it's over 90 for sure, okay?
Yes, it was hard to tell because all the limb loads, the leads, they had the low voltage, so it
Yeah,
was kind of hard to tell.
it's true, but if you compare, let's see the size of 2, 3 AVF, what you can see, that's about 2, 3, about the same. So it has to be around the middle, so around 90. That's okay. That's
Okay,
fine.
90 degrees. So 90 degrees, yes. And it's rather rhythmic. We can see the P waves. But what's interesting is that if you look at lead 2, you can see that the P wave has an interesting shape. It's more pointed. So on the beginning side, which means that right atrium is more enlarged than the left atrium. What?
No. Can you enlarge, let's see, in V1?
Oh, in V1, okay.
No,
Okay.
V1. You said
Oh,
V1.
V1, yes,
Okay,
V1.
V1, do you see that the initial
Yes,
phase is okay. However, the terminal phase is deep and
is left
wide.
atrium, yes.
Exactly. Now, if you
Yes.
go back to lead number 1, go back to lead number 1, and what you do see in the P wave, again, is nudge one and wide one. So we do have a P mitrale. Exactly.
Hello?
Hi, it's okay. P mitrale.
Right, because we, hi, yes,
Okay.
Pimitrale, because it's about more than 120 milliseconds and the left atrium is enlarged, so we can see that.
Okay.
Okay, and we can see what's interesting is the deep S waves in lead V1, V2, V3, and V4 as well. And we can see the poor R wave progression along the precordial leads. And what's interesting is the V6, we can see the non-specific T waves.
I would say the R wave in V6. That's
Yes,
notched.
R wave is also interesting. So we can say it's an incomplete hemiblock left.
No, not a heavy block. That's an incomplete left bundle bench block.
Yes.
Okay, it's not
Left
hemi
bundle
block.
bench block.
That's an incomplete left bundle bench block because you do see this notching of the R in V6. Plus, all the way you do see this RSS very deep S wave on the right side. So that could indicate a left bundle bench block, but because it's not wider, this is, we have to say that's an incomplete one.
Yes.
Okay. Anything else?
Maybe the person is obese, seeing that we have a low voltage. I'm not
Possible.
sure. Yes.
Yes, it can be. Yes, can be.
And what's interesting is the biphasic P waves, as we have seen in V2 and as with the left atrial enlargement in V1.
Yeah, that's the left atrial enlargement. That's it. This period. Nothing more.
Yes. Okay.
Don't try to find more.
Okay.
Okay, thank you.
Thank
All
you.
right, the next one goes to, okay, Isol.
Yeah, I'm here.
Okay, can you share your screen?
Sure.
Sure. Waiting. Mm-hmm.
Right.
Right.
So first of all, I would say this is the rhythmic thing. Like if it point out this QR in our interval is quite rhythmic, and in every other lead it's the same. And then the heart rate, I would say it's 85 BPM. And as of the axis, if we say this equiphasic or biphasic lead as a lead one, and we can say maybe minus negative or plus minus or plus 90 degree should be our option. And we see the plus AVF, so I say it's a 90 degree in hard axis.
Okay, very good.
We have a normal axis hard. And starting with the P wave, we can see this P wave in V2. So we see every P wave is conducted.
But let's see the PR interval, because somehow it
PR
looks...
interval. It's a prolonged PR interval.
Very good. The PR interval is prolonged.
Still, we see every P wave is conducted. So we say the first degree of the AV block.
Correct. Okay, very good.
Then looking into the QRS complex, in the lead two, I can say this is within a normal timeline or time range.
Yes, a little bit looks like it's wide, but it's still in a normal range. Very good, very good.
But if you take a look, the V1 and V2, is it wider than normal?
No, I don't think that's about maybe 3 or 2.5, so it's borderline. But it could be wide. It could be wide as well, and especially if you focus on the P wave in lead number 2, a little bit flattened.
Yes, true.
Okay, so far we do have flat P wave, elongated PR interval, a little bit wider QRS complex. Okay.
Because so far we've had the flattened P wave, and then if we move to the ST segment, we see this. Maybe the elevation of the ST segment is...
No, it's not elevated. The ST segment is not elevated. However, as you see here, that the T wave in V2, V3, it's very tall.
P wave in the...
T, like Tom.
Yes.
It's very tall.
Yes, it is.
Especially you can see it in V2.
Yeah, here.
So what could it be? Almost the same as an R wave.
True.
So flat P, PR elongated, widening the QRS, and the tall T wave. That could indicate the movie that you should watch it.
Hypokalemia.
Thank you for helping me.
Some kind of ion disturbance.
That I haven't watched. Hypo?
Nope. Hyperkalemia. Bouillon again. Yes. Okay. Very good. Very good. That's a hyperkalemia. Okay. Good. This is how the hyperkalemia looks like, especially when you do have a severe one. Don't forget to watch more Mick videos.
I won't.
Yeah, okay. All right, thank you. Let's see. Okay, the following one goes to Elad.
Yes, I'm here.
Okay, so you are together with
Yuli.
Yuli? Yes,
Yep.
you are together. Okay, so Yuli had to wait a little bit. So, can you share your screen?
Of course.
Oh boy, yeah.
Yeah, great.
Okay, great.
Okay, so I can see it's a arrhythmic. So it's arrhythmic. The heart rate is like about 60 beats per minute. Can you hear me?
Yeah, we can hear you, but I
Ah, great.
believe Molnar is gone.
Ah.
Wait a little bit, please.
No problem.
I am sorry, I back. Okay, a little intermezzo. All right, so please, Elad, let's start.
Great. So for me, it looks arrhythmic.
Yes.
The heart rate is around 60 beats per minute.
Okay.
It's a normal axis because the lead number one is positive, the AVF is positive as well.
Mm-hmm.
Well, if I'm looking, so the QRS, it's a bit like wide.
Okay, what about the P wave?
There's a P wave, so it's a sinus rhythm.
Mm-hmm.
Yeah, so like looking at the QRS, it looks to me pretty wide.
Okay.
And the PR interval looks pretty, for here, it looks pretty narrow, and it looks to me like the WPW.
Correct, okay.
And since the V1, the R wave is positive, so it's the type A.
R wave is always positive, so I think that's the mostly is negative, so I would say that's a B.
Okay,
That's a B. Okay, that's a B type. Okay.
Okay, and I'm not sure, but maybe I can see here in the V1 the M, and in the V6.
No, nothing. You don't see more that you need to see it. Okay, that's fine. So it's nothing. Only a WPW syndrome that you do have. That's it. Pathological Q wave.
No.
No. Okay, so that's it. Only a B type. Let's see, WPW syndrome. That's it. Terrific. Good. Okay, now let's see. Hoo-hoo, Patrick. Are you here? Chukwandula? No, he is not. Okay. Sumir?
Yeah, I'm here.
Okay, good. Can you share your screen?
Yeah.
Okay. Meanwhile, I can tell Yuli that you will get ECG number 268 because Patrick is not here, so you can have his ECG, okay?
Okay.
Good.
Okay, so
it's rhythmic.
Mm-hmm.
And the heart rate is 50 beats per minute.
Mm-hmm.
The axis.
Wow, that's an interesting ECG. Okay.
The axis, the lead one is positive,
Mm-hmm.
and AVF is negative.
Okay.
And lead 2 is negative. So
Okay.
it's axis deviation.
Well, it's about equiphasic delete too, but it's fine. Doesn't matter. Okay, left axis deviation. Okay.
Okay. And the P wave is normal.
Mm-hmm.
And the PR interval is normal.
Mm-hmm.
QRS is normal.
Okay, before you jump to the QRS, what do you think? Is every P wave conducted?
Mm.
Hmm? Okay, don't forget it. I'm going to take over and share my screen because I can enlarge it. Okay, now look at this. In V1, if you look at the bottom, okay, this looks like we do have the same kind of P waves. Okay, this looks like the T is maybe here. But if you go to lead number 3, can you see this little notch?
Mm-hmm.
Tail of the P wave? So
Yeah.
that is a P wave.
Oh, okay.
Ha ha! Now you can share your screen again, please. So this looks like as an AV block, but because it's rhythmic and because every second P is conducted, this is what we say, that's a 2-to-1 AV block. Yes? If I said so.
Okay.
Sometimes the P wave can be hidden in the T wave. It's very difficult to see it, but here we can see it in V1. That should be a second P. And if you see that one, that's okay, because now we do have a sinus rhythm. It's around, let's see, the P coming in every, let's see, 100 beats per minute. But because every second P conducted, this is why we do have a 50 beats per minute. And it's rhythmic.
So what is it? Is it a second degree?
That's a 2-to-1 AV block. And we said 2-to-1 AV block is a, we have a different entity, but that's a second degree, the highest second degree block that we could have, okay? What is called 2-to-1 AV block. Okay?
Okay.
Go on.
And
pathological Q wave, because you already said that the QRS is narrow. You already said about the axis. Okay, let's see pathological Q wave. Do we have?
No.
Are you sure? I think if I'm pointing this one, you can have some blue. Yes. Can you? Anybody can see something when I'm pointing now? Any blue mark or nothing?
No. You're not shared.
Yes, I thought. Yes, I thought that we do have something. Okay, let's give see the cursor. I want to have my mouse, please, to control your screen. Okay, come on, come on, come on.
Oh, okay.
All the way up? Yes, thank you. Okay, now, if you go here, all right, you can see a Q wave in lead number 2. Lead number 3 as well, yes?
Mm-hmm.
And in AVF. And in these leads, we do have ST elevation as well. It's more than 1 millimeter, yes?
Mm-hmm.
Okay, can you see it?
Yes.
All right. Now, because we do have an inferior Q ST elevation, this has to be a acute inferior MI. And we learned that inferior very frequently comes together with posterior. And what can you see in V2, V3? Only V2, maybe V1, ST depression, yes?
Mm-hmm.
It's more than 1 millimeter. So possible we do have a posterior extension of this MI as well. So the inferior posterior acute myocardial MI we do have, and a 2 to 1. And that's fitting very well because the AV node and the bundles and the inferior part of the muscle is usually supplied with the right coronary. So this is possible. We do have this MI or this plug or thrombus in the right coronary. Okay, this was clear?
Yeah.
Okay, Alexander.
Yeah, Alex will do. Thank you.
Okay, now are you going to share your screen?
Oh, yes, I will.
Oh, yeah. Okay, great.
Let me move it over. Here we go. Right. Well, there's a lot going on here. Can you see it?
Not yet.
No?
No.
Oh, there we go. Now.
No.
Let me quickly.
You can do it slow as well, slower.
Screen 2, screen 1. Wait, let me unshare real quick and then.
You can share your whole screen if you wish, and after you can choose which one.
Now
but it should be open. Now it should
Here
be
we go.
open. Whatever you want to show it. Nope.
Yeah. Do you see now?
No.
Oh, come on. What's going on?
How many screen you have? 2?
2, yeah.
Now that's a problem. That's a problem that usually if you have 2 screens, relatively the sharing is not an easy one.
Do you see something now?
No.
Okay, let me try on the first screen then.
Okay. Yes, full screen. That should be work.
So let's go here. And, last try. If that doesn't work, you will share. Okay.
Yes.
There we go.
Okay.
All right. Well, there's a lot going on here. Let's start first with rhythmicity. It seems rhythmic enough to me.
Okay.
Heart rate. Down low, we see a bit less than 3 big squares, so it's slightly above 100. So we're talking slight tachycardia.
Okay.
Now, well, oh wait, the axes first. Well, I'm not sure about this because, well, I mean, the 1 is positive, but if we look at AVF here, mostly positive, I guess.
Well, let's make it equiphasic. That's fine.
Equiphasic. So, I mean, it could be normal, but it could be a left axis deviation, I guess.
Okay. You can say 0 and normal. Doesn't matter.
Yeah.
Okay.
Okay. Right. So now P wave. P waves confuse me.
No.
There is a P wave, and we also see that the distance, the PR distance is greater, but it is rhythmic and we have no skip beat. So we are talking about a first degree block. The P wave itself, it's weird. I'm not sure if this is a left atrial hypertrophy or.
I don't think so. I don't think so. No.
Well, what's then P mitrale?
No. I don't think that we do have any kind of P mitrale, but it looks strange. It's true, the P, and it's very long, the PR interval.
Yeah.
Okay. No, it's not. Okay.
Okay. But there's a lot going on in QRS. So we do have pathological Q. And we do have an ST elevation and in 2 and 3. And we do have a reciprocal depression in 1.
Okay.
So we are definitely talking about ST elevated MI. And given how it's going up here and here, so sort of like convex shape, so it's probably, I don't know, transmural ischemia?
No, it's enough if you do see the Q wave, pathological Q wave and
Okay.
ST elevation. That's good for an acute inferior MI.
Yeah,
period.
That's acute inferior.
Okay.
Yeah.
And usually the inferior comes together with
posterior. And we see in
posterior.
V2, we do see a depression.
Well, I don't know whether this is 1 millimeter or not, but I don't think that's any kind of ST depression. However, if you do see a very tall R wave, because normally we do have a transition when the R bigger than an S in V between V3 and V4, and here V2 the R is bigger than S.
Yeah.
So relatively, and V1 that R is relatively big. So it looks like on the back we could have a pathological Q wave, but there is no ST changes. Now, or you can emphasize that that's possible. That's all the posterior MI together with the it's a inferior acute MI. This is what you can say. This is one thing. Or you can say that acute inferior posterior. I think nobody will say the different things. Okay.
Right. And I do have another question. In some of the elites, we do see sort of like the overall shape is kind of wavy. Is this like a baseline artifact with like breathing?
That's a artifact. Another thing that you can still see here in V5, V6, you do see this ST elevation, and that's again can be due to an inferior MI. Usually in V5, V6, that can represent a little bit on the inferior part, the diaphragm part, or the posterior part, a little bit is over there. So that's what you said. We do have a sinus rhythm first degree AV block and an acute inferior posterior myocardial MI. This is what we have. Yes.
Yeah. Okay.
Okay. Good. Very good. All right. The next one, Mate.
Yes, sir. Can you hear me?
Yes. Everybody can hear you. Can you share, please?
I hope so.
You hope so. So far, nothing. Yes.
Can you see it? Nice.
Yes, we do.
So, this tracing is rhythmic. And we can see bit more than four large squares in the R2R interval. So I would say about 70 beats per minute.
Yes.
We can see a T wave, although it's very small.
Yeah, but don't jump to the T wave very far, the T wave.
No, not T, but sorry, the P wave, not T.
Okay, that's
the
okay.
T wave is very small, but it's there, so it's sinus rhythm.
Yeah.
In lead number 1, it is positive. In AVF, it's negative, so it's left deviated.
Yes.
I would say lead number 2 is also a bit negative. So it's an extreme left deviation.
Okay.
And so it should be between -60 and -90 because AVR is also negative.
Yes, but if it's negative, it's between -30 and -60.
Oh, okay, sorry.
If you had positivity in AVR, that could be -60, -90.
Okay, sorry. So it's extreme left deviation between -30 and -60 degrees. So like I said, the P waves are very weak, but the PQ interval looks normal to me.
Okay.
The QRS complexes are there in each lead, and they are also, I would say, quite normal. I can see an ST depression in lead number 2, 3, as well as in AVL and AVF here. Of course, AVF is inverted. From the ST depression, I wasn't sure because there's also this M-looking QRS complex in V4.
Okay. In AVL, the ST depression can be explained due to the 2, 3, and AVF ST elevation. That can be the mirror image. That's okay. Because lead number AVL and 3, it's almost opposite. -30 is AVL and 120 is lead number 3. Okay.
Okay.
So you do see in an inferior acute MI. That's good. Looking at the chest leads, you can see QS complex in V1, V2, V3. And if you look at and enlarge a little bit V4, let's enlarge it. You can see that the looks like is a W, the QRS complex.
Yes.
But this doesn't show anything, only that you do have a pathological Q wave in V4. This is only one that you have to consider, because there is no other notching in V1 or V6 or V5.
Okay.
Okay, so because there is no other ST elevation or T inversion in V2, V3, and V4, you can say that's an old anterior MI.
Okay, okay.
So this patient had an anterior old MI, and now he has she has a inferior acute MI.
Okay.
Okay. Good.
Professor?
Yes.
I do have a question. How, like, what exactly is the distinction between old and current?
Okay.
When we talk about MIs.
Acute. Okay. Acute or
acute or
okay. Acute usually meaning that I show you, but the last time I did the same, I'm now doing the same again for you. Okay. All right. Sharing this board. I did the same. Yeah. Especially I explained you, I think, the posterior one. Okay, let's see. Hyperacute. I'm typing. Hyperacute. How the hyperacute looks like? The hyperacute looks like when we do have, wait. Where is a drawing? Yes. So when I do have a dome-shaped ST elevation. Okay? Acute. Come on. Acute. Acute. We can have, okay, almost. We can have Q wave and still the same as before, or we do have Q, ST elevation, and negative T wave. Okay? Yes. Subacute. Subacute.
T wave is separated.
We do have only Q and negative T. And when we talk about old or definitive, I would say old, we said that whatever is left, only the Q wave and nothing else. Okay? So these are the different types of, let's see, that's a current. We can say that these all the current one, okay? And this is at least more than 1 week. And this is more than, let's say, a couple of months. Okay.
All right. Thank you very much.
You're welcome. Okay. Oh, stop sharing. Great. Now let's see who is left. Nashiki?
Nasike, yeah, that's me.
Nasiki?
Nasike.
Nasike. Can you share your screen?
Yes, 1 second.
Thank you.
Is it working?
Yes.
Okay. Can you see my cursor?
Yes, I do.
Okay, so just from looking, it looks rhythmic. I would say there's a heart rate of about 120, so it's tachycardic. There are P waves present and normal sinus tachycardia. The axis I said was extreme left deviation because 1 positive, 2 and 3 are negative.
Okay.
That can indicate a left anterior hemiblock.
I won't say it.
Okay.
You can enlarge it. Let's enlarge. Let's see a little bit to an AVF. Let's enlarge to an AVF. Now, if you enlarge to an AVF, you can see that. Let's compare. Can you share? Let's see your cursor.
Can you see it? I don't know how to make it.
Okay, go up, all the way up, and you can see the control panel. And if you punch it, the control panel is falling down, and you can see some mouse, a mouse over there.
Remote control.
Yes, remote. That's it, remote control, and sign it to me.
Okay. I think
yes, thank you very much. Okay, now, as you see here in AVF, this is a PR interval, okay? And if you compare, down is a Q, up is a R. So if you look at this one, this is not negative, this is positive AVF. But as you see here, we do have a ST elevation and a Q wave as well. Okay.
But then what about 3 also, lead 3 also being negative?
Lead 3 is negative, that's fine, but AVF is not.
Okay, so you would say that this is a normal axis?
Yes.
Okay.
It's about maybe, let's see, the 30 or so, but a little bit more negative, maybe 20. That's okay.
Okay. So the QRS complexes generally.
Let's reduce the size. Okay, good. So we do have a sinus tachycardia. Okay, the axis is normal. The P wave, the morphology of the P wave is?
Looks relatively normal, but
okay.
2, oh no, that's, I think what I'm
That's
looking.
okay, that's normal, that's normal. This is not so tall, believe me, it's not so tall, okay?
Okay, but in leads 2, 3, and AVF, I can see the ST elevation.
Okay, and the Q wave, as I said, because the R wave is not too big, okay, yes.
So that, because of the Q wave, that indicates the acute MI, because there's the Q and the ST elevation.
Very good.
Then I think it would be inferior because it's seen in 2, 3, AVF.
Very good. Okay, so we do have an acute inferior MI. And if you do have an acute inferior MI, you should look at the posterior. Can you see any sign of the posterior?
That's one of the posterior leads again. V1.
V2, okay. That very tall R wave. Can you see this? The R wave is so big.
Yes.
Okay, so that could mean that on the back, we do have a Q wave, a pathological Q wave. And if you look at the ST segment, if the ST segment is more than 1 millimeter, so deep Q and ST, so that can indicate a posterior as well. So we do have a inferior and posterior acute MI.
The ST on V2, how would you, sorry, can you repeat what you said about the ST on V2?
ST in V2, if you look at in V2, well, you have to compare, let's see, the ST depression. Okay, the ST depression, I cannot.
Use the other the other pen. It's like more free, if that makes sense.
It's only one thing that, okay, I can use another pen, but I cannot modify or, okay, oops, oh, Jesus Christ, no, Control C. I cannot go back, that's fine. So, and so that meaning that if you compare to the PR interval to the ST segment, you see it's about 1 millimeter done.
Yeah.
So this is why you can say that is the ST elevation on the back.
Okay.
So that could mean that this patient could have a infero-posterior MI.
But you would need to have the high R wave and the depressed.
Yes, and the R is very big. So that's, if you look at the R is too big because the RS ratio, the R should be bigger between V3 and V4. Okay.
Yeah.
Okay. Now wait a little bit, please. You have to wait.
What was that?
Probably a grandson, grandchild.
Oh yeah, true. I thought maybe somebody was like a video or something. I don't know.
Okay, so this is why it's happening in this case. Now, can you wait about 5 minutes? Can you give me 5 minutes, guys, please?
No problem.
Okay, I started, okay?
I'm not sure which one you gave me. Was it 268?
That's fine. I never seen this ECG. I was waiting for it, but now I got it. That's great. This is yours. And you have a very good company, so a lot can help you.
Give me just a second. Okay, so first of all, I think it's arrhythmic.
This is arrhythmic, you said?
Yes.
So it's not rhythmic. Okay, good. So far, so good.
I think it's about 100 beats per minute.
That's fine to me.
I think the axis is normal. And I guess that I don't really see P waves.
Me either.
So I would say it's atrial fibrillation, maybe?
Not maybe. That's an atrial fibrillation.
Okay. And I also see wide QRS V1, V2, all of the chest leads. So, and I think that I see on V3 and V2 the notched R. So it should be RBBB. Yes. I don't know if anything else is.
Well, pathological
maybe there
Q
is
wave.
pathological Q wave on V1.
ST segment. V1, no, we don't have. We have an RSR pattern in V1.
Okay.
So there is no pathological Q wave. However, we do see a secondary STT changes that is due to the right bundle branch block.
Okay.
That's it. See? I think you are getting, and everybody getting better and better. So for the next, I again give you some ECGs to practice, okay? But you can watch the all ECGs that I shared with